All right, well, I'd like to thank everyone for coming tonight. I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation, which is a community development finance institution and a not-for-profit that's been around since 1993. It was started in the Dinkins administration after the mayor realized that there was insufficient health care, and he believed strongly that health care was the right of the people and the responsibility of the government. And so a group of city workers got together, including Rhonda Kotelchuk, who's the founder, and created this organization, which has since gone on to both help finance community health centers and primary care across the country, as well as to try to help primary care be as strong as it can be, both in terms of operations as well as thinking about how we promote appropriate legislation, regulation to support primary care and what it needs. This is our 4th annual Primary Care Summit. It's part of our Innovation Circle series, which is a way in which we bring folks together to talk about important, occasionally controversial issues around primary care. And tonight's discussion is of critical importance. We're going to be talking about the primary care agenda in the Trump administration. Our program will last about 90 minutes. We'll have some we'll have some presentations and some conversation up here. Then we'll open it up to the floor. There's some mics on the floor. By the way, this is being videotaped. We hope to put it on our website, so just to let you know that. And after the program, we'll have some wine and beer and some additional snacks, and hope that you all will stick around to continue to have the conversation. Before we begin, I want to acknowledge and thank the PCDC corporate circle sponsors whose annual support enables us to put on events like this. Many thanks to Athena Health, Affinity Health Plan, Custom Computer Specialists, Manat, Proskauer, Crystal & Company, Rivkin Radler, Goldman Sachs, Centers Healthcare, and CTG. Many of you are in the audience tonight, and thank you. So, we're here tonight to talk about primary care, the Affordable Care Act, and the new Trump administration policies affecting primary care. PCDC believes that primary care is transformational and is a cornerstone of healthy, thriving communities. And primary care is more than just a doctor and a patient in a room together. It's essential to what has been developed by the World Health Organization as the definition of of health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, and not only for individuals, but for communities. And PCDC holds a very broad definition of primary care. We think it is first contact with the healthcare system. It's care throughout the life cycle from a newborn to the end of life. It is non-disease specific. It is patient-centered. It encompasses physical health, behavioral health, women's health care, oral health care, and everything else that's needed. And to reach its promise, we believe that primary care must be accessible, high quality, affordable, culturally competent, and reimbursed fully. On March 23, 2010, then President Obama signed into law the Patient Protection and Affordable Care Act, known as the ACA or Obamacare. It is often thought of as primarily increasing insurance access, and it indeed accomplished that for close to 30 million people. But it also encompassed important consumer protections, increased access to care, supported public health, and improved the quality of care. As you all are well aware, the Trump administration has begun to implement campaign promises in many arenas, including policies on immigration and refugees, education, and the environment, all critical, all of concern, and frankly, all posing a potential threat to public and population health. And tonight, on the last day of open enrollment in health insurance developed by the Affordable Care Act for the current year, tonight we're going to focus on the potential impact of Trump administration policy on health care with a special focus on primary care writ large, starting with the impact of implementing a major Trump campaign and Republican promise, which is to repeal and to replace the Affordable Care Act. We have with us tonight 4 health policy experts and practitioners. Their bios are in your program, so please take a look. We have Deborah Bachrach, who is a partner at Manat Health, providing expert and timely health policy analysis. Dr. George Petit, who's the Regional Senior Vice President for Beacon Health Options, one of the largest behavioral health managed care organizations in the country, serving more than 50 million people. Dr. John Ruggie, who's the CEO of Hudson Headwaters Health Network, of federally qualified health centers in the North Country of the state, and a member of the New York State Public Health and Health Planning Council, and Dr. Cynthia Summers, the Executive Vice President at the Guttmacher Institute, who's a premier research and policy organization committed to advancing sexual and reproductive health in the US and globally. Over the course of this evening, each of our panelists will talk specifically about what we know or believe will be or may be the Trump administration primary care policies and timeline for implementation. Along the way, we will offer some suggestions for when and what might be key areas for action to affect policy, though that will be the work of all of us and many others over the coming weeks and months. So let me first set the stage. Many people in this room are well-versed in health policy details, others may not be. So we will make sure as far as possible, we will stay away from acronyms and will provide background as we can. So simply put, over the last 6 years, the Affordable Care Act has supported primary care in important ways, including increasing insurance coverage for 20 to 30 million people who are covered through new individual health insurance or Medicaid, incentives to use primary care, including elimination of out-of-pocket costs for preventive services such as contraception, vaccines, and the Medicare annual wellness visit, key consumer protections for health insurance, including the elimination of annual or lifetime limits, the exclusion of pre-existing conditions, and the inability to charge different premiums based on gender or health status, all critical consumer protections. The ACA also addressed chronic disease through both clinical and community prevention activities and programs to increase and improve the health of people with multiple behavioral health and medical conditions. It encouraged integrated systems of care for providers to support higher quality care and rationalize reimbursement. And there was a lot in the ACA about workforce loan repayment and training programs. And if that wasn't enough, there was also $11 billion over 5 years in the Community Health Center Fund to support federally qualified health centers. Through the Center for Medicaid and Medicare Innovation and other funding streams, the ACA promoted primary care reimbursement and delivery system reform, often referred to as value-based payment, but there were other types of reform as well, which emphasized quality, patient outcomes, patient-centeredness, care coordination and management, especially for high acuity and higher cost patients. The ACA also expanded the reach of the mental health parity law, defining behavioral health as an essential benefit and therefore required in any plan sold on the exchange as well as in any Medicaid expansion, and all insurance plans are now subject to the mental health parity law. It encouraged and incentivized widespread use of electronic health records to support effective data sharing and to improve health. And it understood that there was a growing connection between public health and primary care, especially as it relates to the social determinants of health. But let us be clear, even with these critically important primary care gains, there remained, in PCDC's view, significant challenges to primary care, not all of which relate to the ACA, but relate to the broader question of primary care policy. First, insufficient resources to support primary care. As you all probably know, primary care gets about 5 to 7 cents on the healthcare dollar. There were extremely complex and I would say onerous reporting requirements, with one study suggesting that over $50,000 per primary care FTE is spent on reporting alone. There are many, many innovation projects, both at the state level and at the local, at the federal level, which had different programs, different ways of working, different clinical indicators, and different reporting requirements, making there a lot of noise in the system for primary care providers. There's an insufficient and underfunded primary care workforce at all levels, and uneven clinical quality, even among the best primary care providers, that we can see in rates of uncontrolled hypertension, diabetes, continued high rates of smoking, opioid addiction, inadequate provision of women's reproductive health services, and so forth. And there's still an estimated 27 million people in this country without health insurance. In the next 4 years, with a very different federal landscape, we now must ask the question, what will be the new administration's policies on primary care? And tonight we're going to be looking at what we currently know, what we think might happen, and what some of the issues are to watch for as the new administration unfolds. So we're going to start with Deb Bachrach from Minot, who's going to give us an overview, particularly about repeal and replace. And then we're going to ask each one of our panelists to chime in on the area that they are specifically an expert on. We're going to have some moderated questions, and then we'll open it up for the floor. So let's get started. Deb.
Thank you, Louise. It's a pleasure to be here. So primary and preventive care in the new administration, I'm not going to say a word about it. What I'm going to talk about is coverage, because while coverage doesn't guarantee access, and it doesn't guarantee good health, and it doesn't guarantee, access to reproductive health services or mental health services or substance abuse services, without it, we don't have a starting point. So I take the position that it is the foundation for everything else we do. And it's at incredible risk. And I want to talk about it in two contexts, through the lens of Medicaid. First, about repealing the Medicaid expansion. And then second, what does it mean to restructure Medicaid's financing and to go to a block grant or a per capita cap? A radical shift in the federal-state partnership funding Medicaid. So let me start with Medicaid expansion. Probably not something most people in this room thought about a lot, because New York, of course, had expanded its Medicaid program even before the ACA. But just as a reminder, what expansion did is it provided states with the money, almost 100% federal dollars, a federal matching rate, to expand their Medicaid programs to all adults with incomes up to 138% of the federal poverty level. Now remember, before this, most states, the vast majority of states, provided no Medicaid coverage for childless adults. Those are individuals between 18 and 65 without a dependent. So it's your 22-year-old student at community college, it's your 60-year-old mom whose kids are out of the house. No coverage. New York was different. And most states didn't cover parents above 50% of the federal poverty level. Now, 31 states have expanded, plus the District of Columbia, and they're covering adults with incomes. A childless adult, it's about $16,500 a year, and a family of three, it's about $27,000. So this is extraordinary for 31 states. Before the election, my entire work was about how do we bring the 19 states along. Now we're talking about how do we maintain the expansion. Now with expansion also came, and Louise alluded to this, for the first time in Medicaid, prevention and preventive services was a mandatory benefit. Before expansion, mental health and substance abuse was not a mandatory benefit. So it changed the landscape nationally dramatically. And it brought 14 million more people into coverage, 11.5 of whom had never had coverage. And it brought $72 billion into expansion states, because right with expansion, the feds were paying most of it. $72 billion. Now, I'm going to keep coming back to the numbers, because all of these years when I've been working on expansion and coverage, that's all anybody cared about. We got done. They didn't care about the moral imperative. If they had, 50 states would have expanded, right? They didn't care about the health outcomes, or 50 states would have expanded. So I've become fixated on the dollars, because that's what people listen to. So 31 states in 2016 got $72 billion in federal funds that didn't go to the 19 non-expansion states. That's $8 billion to New York State. So as a result of the expansion, we pulled in an additional $8 billion in 1 year. Now you say to yourselves, okay, but New York State was a leader. That's true. And we had expanded coverage to childless adults and to higher income parents before the expansion. The expansion bought out a lot of our costs. That's what that $8 billion is. It's dollars we used to spend. So now tell me, does New York, that's facing a budget deficit in 2017, have the dollars to replace that $8 billion? Governor says he does, but let me keep telling you all the other dollars we have at stake. I'll take the governor at his word, just like I take the president at his word that under repeal and replace, nobody will lose coverage. So We're good, not to worry. So New York's got a problem. I've got 8 expansion states that say if the federal matching rate goes down 1 percentage point, the expansion terminates. It's a poison pill. So again, I know I have a New York audience here, but think about what that means around the country. And in every state, even without my poison pill legislation, those new federal dollars are embedded in their budget. So it's going to cause a huge budget gap, which it's a budget gap, and then we have to figure out, can they maintain the expansion with a regular matching rate? And I will tell you that some of the repeal bills, and the repeal bill that, the one reconciliation bill, which is how we're going to repeal it, that passed in 15, and was vetoed by President Obama in 16, not only repealed the expansion, but repealed the authority to expand to childless adults and parents above the prior income levels. So we have a huge question is, what does the repeal look like? When will it take effect? What will happen to states that haven't expanded? And will states that did expand still have the authority to expand even with regular matching dollars? All an open question. So let's just come back to New York, because I want to just come back to your dollars again, because we got a dollars problem here. Then we have something called the Essential Plan, right? It's the basic health program, is the statutory term. It's the Essential Plan. It offers very low cost coverage to individuals with incomes below 200% of the federal poverty level, because we take all the subsidies and we come up with a lower cost product. Very important for those individuals just above Medicaid level. But for New York, it allows New York to save almost $1 billion because legal immigrants that can't get Medicaid, because they haven't been here for 5 years, go into the Essential Plan. So we can use tax credits, subsidies, instead of what we were doing, which is almost all Medicaid dollars. We're saving almost another $1 billion. So add that to my $8 billion. Then, here's my other problem for New York and all states, is CHIP, the Child Health Insurance Program, sunsets on October 1st. In CHIP and in the Affordable Care Act, subject to repeal, is a 23% bump in the matching rate. So I don't know how much that brought into New York, but Oklahoma's in a panic that they're going to lose this because because oil dried up, or the price of oil dried up. Oklahoma's in a panic. They don't know what they'll do if they lose the 23% bump. All of that is what's at stake with repeal. So how are they going to repeal? They're going to do it through reconciliation, because that makes it filibuster proof. So they only need 51 votes. It will probably happen in February or early March. And again, they won't make it effective immediately. It will be effective in 2 or 3 years. What happens in the interim? What happens when it goes into effect? Do we still have authority? And will that $72 billion be in our base, or will, under the rules, budget rules in Congress, is it removed? It could well be removed if we don't do replace at the same time we do repeal. And the bill that passed and President Obama vetoed removed the revenue provisions, the tax provisions that raised the money to fund the subsidies in the Medicaid expansion. And if that's removed in repeal and not preserved for replace 2 years or 3 years down the road, what do? We do not have the dollars. So that's a huge issue. So now let's come back to block grants, or per caps, or capitated funding. So now we've repealed, I got one problem. Well, we have another problem, which is Congressman Paul Ryan and HHS Secretary nominee Price are committed to moving Medicaid to a fixed funding scheme, a capped funding, either through block grants or per capita caps, and I'll come back to both of those. But here's what you need to know about either type of fixed funding. One, it's no longer guarantees a federal match. So right now, when New York spends money on Medicaid beneficiaries, as long as it follows federal Medicaid law, the federal government matches it. So we spend more, federal government gives us more. That guarantee, that open-ended commitment, gone. It's capped. All of the block grant proposals and per cap proposals reduce the federal dollars and cap it. That is the goal. it is to shift the risk from the federal government to the states, because now the federal government will know what it has to spend. It's X billions of dollars, and it knows it won't have to spend more than that. The states, on the other hand, know they will only get X billion dollars, but if healthcare costs or enrollment go up, who bears the cost? How much can we cut eligibility? How much can we cut benefits? How much can we cut provider rates? Big problem. So that's what we face with both of these proposals, block grants and per caps. The only proposal that CBO could model out found that we would lose, states would lose over 10 years, $1 trillion. Medicaid funding against baseline would be cut by 25%. It consolidated CHIP funding in there too, and the overall cut was 33%. 33% over 10 years. Now, we shouldn't be surprised, because when we look at block grants in other programs, here's what we find. We have a social services block grant. It was put into place in 1982. Since then, it's lost 73% of its value. Remember in 1996, with the welfare reform, that we went to block grants. That was 96. Since then, it's lost 33% of its value. So that's what we're facing. So a block grant is a fixed amount of money. That's all you get as the state. Maybe you have a matching requirement, and maybe you don't. But that's all you get. So all of enrollment risk shifted to the state, right? We have a recession, enrollment goes up, we've got a cap. Sorry, costs go up, we've got a cap. And a per cap isn't an overarching cap, but it's a fixed amount per enrollee. And it's usually done like this: child, adults, the elderly, and the disabled. So you get a different cap for each of those eligibility groups. So now let's think about how that's going to work out for New York and for other states. So the first question is, when you have either a block grant or a per capita cap, what happens with the next public health crisis, the next opioid epidemic, HIV, Zika? I don't have any extra money to spend to address these public health crises. What about a new blockbuster drug or other medical advances that are not built into the base on which we set the cap? Oh, and remember, I spend a lot of time trying to generate food fights among states, because what base year do we use? If we use 2016, expansion states have an extra $72 billion. So right away, one of the reasons we've never, and Republicans have consistently come up with this idea, it's never been able to get through, because what's good for Texas is bad for North Dakota. It's good for, Florida isn't so good for Washington State. So that food fight actually serves as to benefit us all. Okay, so then we could have a natural disaster, Hurricane Katrina. We could have a man-made disaster like 9/11, where Medicaid stepped up for after September 11th. None of that can be accommodated in capped funding. And then the block grant, of course, is the worst, because we can't even accommodate a recession. We can't accommodate enrollment growth that comes about with a recession. So then let's look on a per cap. On a per cap basis, New York spends more than any other state in the nation on disabled enrollees. Right, Art?
You're right.
I know. Yes.
We're not embarrassed.
I'm not, so we spend more than any other state. Now, what if we go to a state specific? Well then, okay, at least we're getting that same top number we were before. But we're equally likely to go to a national average. And if we go to a national average, because we don't like New York, which overspends, we're in big, big trouble. So I go into states that are at the bottom of the disabled and elderly, and we're right at the top on elderly spending as well. But I go into states that are at the bottom, and they're completely freaked out, because they're at the bottom and they have no ability to move if they don't get the national average. So you can see right away, how are we going to do this? Oh, and then we're going to trend based on CPI. Now we trend, it's all state specific. Costs go up, federal matching goes up. all of these proposals trend on CPI. And, oh, I didn't put it in here, but CPI is way below medical inflation. It's way below where New York's inflation trend is. So that's why we lose ground in any kind of block grant. So now we've got it, we've figured out an allocation formula, and we have to live within it. Let's make it a per cap, which is marginally less bad than a block grant. Where do we cut? Now, where does Medicaid spend money? We spend money on the elderly and the disabled. We spend money on the dual eligibles. So nationally, 2/3 of people in nursing homes rely on Medicaid. Is that where we're going to cut? What about half of Medicaid spending is on elderly and disabled? So I just don't know where we're going to cut. So I'm almost done. She's like she's giving me the evil eye. Here's the trade-off. So you think to yourself, what governor in their right mind could want this? Now you get that there might be some, folks in Washington who want to fix the federal risk, right? That is their main concern, is the federal deficit. But why would a governor want this? Our governor doesn't. I'm not so, the blue state governors not so much. But you've got governors who are saying, just give me the money and I can spend it better. I know it's less money, but I'll have more flexibility. I don't have to cover all of those adults that should be working. And I won't have as great a match. So the pressure on my state budget will be less. That is the equation for some governors. So I would rather present it as flexibility, more flexibility, less dollars. It seems to me to be a no-brainer. And for many governors, including Republican governors, it is. But there are some, Governor Scott was right out there in Florida going for his per caps. Of course, when he put in the letter to Representative McCarthy that he wanted a per cap, he said, and I wanted to go up based on Florida specific this, and you need to add this, and you need to add that. But you see, that's not the point of it. The point of it is to fix the federal exposure, not to accommodate state needs and human needs. So I'm going to bring it to an end now with, I focused on the dollars and I focused on the coverage because I honestly believe that's the starting point. Because if you don't have coverage, we can't debate how to deliver care. We can't even have the conversation Louise wanted us to have about what's the role of primary care, because we don't have coverage and we don't have the funding stream to provide the coverage, much less the care. So I'm going to stop at this point, turn to my colleagues, or back to Louise, to sort of take us back to the human side of all of this.
All right. There
on that upbeat note.
Yeah. We're gonna move now to the psychiatrist who's going to help us manage our feelings about this, but really to talk about behavioral health and what the issues are and what we might see. So George, why don't you?
So my expert recommendation is we just skip this and go directly to the beer and wine. So that was pretty sobering. So I've been a public sector psychiatrist for 20 years. I worked for the last year at Beacon Health Options, which is a specialty behavioral health managed care company, and which all we do is focus in on delivering benefits to our members. And as I was, briefly talking to Louise about sort of where we're at, I kind of feel like, the Roadrunner and Wile E. Coyote, and we're sort of running with each other, and all of a sudden, Roadrunner stops, Wile E. Coyote sort of keeps on going off the precipice, and for a second looks around before he falls, and I kind of feel a little bit like that, right? So we're at this sort of juncture in time where I think between, the ACA, the Mental Health Parity Act, and this latest round of the 21st Century Cures Act has really sort of put behavioral health front and center and really allowed parity to be part and parcel of what everyone expects, right? So my concern around all these issues and how the states and the feds are going to sort of jockey around what's going to happen next is worrisome, in that for the first time, I think, coverage has been expanded. More people that need benefits are getting benefits that include, as part of an essential package, mental health, substance use. And to roll that back at this juncture is incredibly worrisome and just detrimental to, I think, where we want to go in terms of ultimately achieving, the outcomes we want. And as a psychiatrist on the panel, I have to say that whether we talk about primary care and the impact that behavioral health conditions, have, or the impact that they have on the cost or the direct cost that they have, is hugely important. And we sometimes lose sight of those conversations when we're thinking about how do we fix a system of care where we don't really focus in on the behavioral health aspects, whether it's the mental health or the substance use conditions. And that gets lost in the numbers, gets lost in the policy debates around these issues. And it's a population, or it's a group that hasn't necessarily been served well and doesn't have sort of a strong advocacy. And I still think we have just way too much stigma and taboo around these issues to be able to really advocate effectively. But I thought in the last 8 years, we had really achieved a tipping point in terms of our ability to be able to start to really hone in on what and how we need to advance the agenda around behavioral health conditions. And this started, over 15 years ago when I was sort of working at the City Department of Health and Mental Hygiene. And one of our first public mental hygiene initiatives was depression screening in primary care, because we felt it was critically important to start that dialogue in primary care and start to destigmatize the notion of there's a screening instrument, you get a number, we can actually monitor and measure your progress in the same way that we would diabetes or any other chronic disease state. And we slowly have, I think, moved further and further down the road of true integration and collaborative care models that we know are evidence-based and work, and then sort of really looking at the role of psychiatry as a specialty company. And I used to go out a lot and do a lot of training, and I would say no primary care doctor would say, I'm not going to treat a regular run-of-the-mill diabetes and refer them to the endocrinologist. They would sort of manage individuals in their practice and sort of collaborate with specialty care. And I think that we've slowly moved the needle in that direction. So I think anything that takes away from that or starts to erode that, I think this is one of the first things that would go, right? Is their ability to be able to adequately identify and manage these conditions in primary care would be a huge loss. I also think that as a specialty behavioral health company, we have really focused in on ensuring that all of our members across all of our lines of business, from commercial, through Medicaid, Medicare, and exchange products, are receiving the array of services that are necessary for them to achieve the outcomes we want. I think the last year has really been important for me to start to sort of pivot us as a company away from the transactional traditional utilization management paradigm to really much more of a collaborative approach to working with providers, and start to think about moving away from volume. We're very fee-for-service still, a lot of volume in terms of the way that we've structured these services, and start to think about how do we achieve outcomes differently to ensure that members are getting the right services at the right time in the right settings and for the right amount of time. I think also sort of open-ended, longitudinal, treatments might not necessarily be where people are at, and maybe more episodic care or maybe more digital enablers are ways to think about this. But all of that progress worries me, because if we start to think about block granting or any other mechanism, we won't be able to achieve those outcomes. And I think the one other area that I've been sort of, putting a lot of hope in is where value-based payment actually starts to work for us to deliver on outcomes that are not tied to just sort of seeing volume increase. So I have to wrap up, but I'm sure there'll be other comments I can make.
Right, thank you. I mean, I think this whole idea that behavioral health is really hit a tipping point, I think is really right, that for the first time it's just integral to the conversation about primary care when you think about it. And I think that is a question about what will happen with that, and will that in fact be the first thing to go. Cynthia Summers, who's the Executive Vice President at Guttmacher Institute, tell us a little bit about what you think is going to happen for women's reproductive health services.
It's going to be great. Okay, so we've already heard from speakers so far about what we stand to lose in primary care, and it's a lot. So I'm going to take a couple minutes and shine the spotlight more specifically on women. As many of you saw on the signs if you marched or if you watched the coverage, the 51%. And the bottom line is that social conservatives who are hostile to women's health, to women's rights, to women's autonomy now control the White House and Congress. And so I want to spend a couple minutes just talking about what that most likely means on the ground right out of the gates. So I think there are three main issues that we need to be thinking about right now. One is contraceptive coverage, that's already been touched on a little bit. One is safety net care, which has also been alluded to at least, and abortion. So first, following Deb's lead, I'm going to start with some basic facts. And according to a recent government report, right now 55 million women are covered by the ACA's contraceptive coverage guarantee. And for those of you who don't live and breathe this, just as a reminder, the contraceptive coverage guarantee requires health plans to cover 18 different methods of birth control at no out-of-pocket cost to women. So what that has done is allowed tens of millions of women to access the right form of birth control that works for them and that works for their family. Particularly the most effective ones like the IUD that have very, very expensive upfront costs. Just as an example there, for a woman who is working full-time at the federal minimum wage, the cost of getting an IUD without health insurance coverage is about a month of her income. So we're talking about a choice between food and rent or birth control. So far, the contraceptive coverage guarantee has saved women and families at least $1.4 billion. And I would say without a doubt, it's going to be gutted by this administration. So full or partial repeal of the ACA, which we're definitely going to see, will leave millions of women without insurance unless some miraculous replace comes along. But also for millions and millions more women, even if they don't lose their insurance, they're going to see their contraceptive coverage hugely degraded. So second, and I'm only going to touch on this briefly because I think Louise was going to ask a question that will be more of a dialogue later, but when you talk about the safety net care, the new administration is poised to make dramatic changes to the nationwide network of publicly funded healthcare centers. Millions of women rely on these centers for contraceptive care, as well as other services like testing and treatment for sexually transmitted infections. And in many cases, and this is critical, 4 out of 10, specifically, this safety net care is the entry point for those women into healthcare, and it is the only form of regular healthcare that they get. The most immediate moves in this direction will likely be the defunding of Planned Parenthood. And I would say by spring, summer, policymakers are likely to take aim at Title X funding in general and shifting funding to other types of providers. And I think I'm not going to talk about that yet because we are going to have a conversation about that a little later. Is that right, Louise? Okay. So last but not least is the issue of abortion. And I think for those of you who follow these issues at all, attacks on abortion are not new as of late. Since 2010, the states have enacted 338 new restrictions on abortion. And that is largely because under the Obama administration, they realized they weren't going to get any traction at the federal level. And so the states have been very, very effective at moving the needle backwards on abortion access in more conservative states. I think what we'll see now is the introduction of several federal restrictions along the same lines, attacking abortion at all sides. Earlier this year, earlier this week and this year, both, Congress already moved to codify and expand the Hyde Amendment, H.R. 7, which is a law that severely restricts abortion coverage for Medicaid patients. So, you know, the impact of these is it's harder for providers to keep their doors open. it's harder for women to access services. And what we know very, very well, without a doubt, from the global context, is that making abortion illegal or inaccessible does not make it go away. It makes it less safe. The best way to improve or to reduce unintended pregnancy and the abortions that follow is to improve access to family planning and contraception, and to have programs in place that help women use it consistently and correctly. So I think I'll stop there and turn it over and we can talk more.
Yeah, so just for those people who may not be as familiar with it, I think the safety net that Cynthia is referring to is both the network of Planned Parenthood providers, but also those who are funded through the federal government's Title X program, which funds women's reproductive health centers throughout the country that include not only contraception, but also, and do not include abortion services, but do include a variety of other kinds of services, including pap smears, sexually transmitted disease, testing and treatment, and so forth. And it is, as I think you said, 4 in 10 women, that's their entry point into the healthcare system, which makes it an interesting question as to where women will go once that safety net may be shut down. So John, Dr. Ruggie, let's turn to you and tell us a little bit about federally qualified health centers, what you think the impact of the ACA repeal and replace and other federal policies might be.
I want to start just by thanking PCD staff for organizing this event. It's really special. As you've heard from Louise, my assignment was to talk about FQACs, but I want to pull back on the lens just a little bit and talk about primary care generally. And to say the obvious, this discussion is a tiny part of a huge national debate with enormous impact on millions of Americans who are on the line. 2 issues. One are our values, and the other is our money. And the value question is, are we committed or not to assure and provide care to everyone? And I think for all of us, there's only one answer, but that's in doubt now. And as far as money goes, I think the question is public policy all about controlling how much money government spends on health care, or is it to be directed to bring health care costs generally into line with other developed nations? That's what we need to do. And that's what the effort has been up to now. And again, to my mind, both of these questions harken right back to primary care, because on the value side, primary care is the caring part of health care. It's where doctors meet patients and follow them along through time and get to know them and be trusted by them, and then by virtue of that have the opportunity to be prudent in the way health care is expended, health care expenditures are spent, and also to coordinate the care all across the system, including those technologists who only have time to look at an organ. What we know is, in round numbers, 85% of healthcare expenditures are in chronic care. And that's where primary care action is. It's not the episodic urgent care. It's taking care of people over time. And the most vulnerable and the most costly group of that are those who are behaviorally disturbed. And what do you know? For the behavioral health patient, 85% of their expenditures are for medical care, not for psychiatric care. This is where the action is. And the evidence is clear. Starting with Barbara Starfield, we know that those populations, those societies that provide more primary care have lower costs and also better quality. And especially compelling are the reports done over the years now and decades by the National Association of Community Health Centers, with the consensus finding being that for health center patients, healthcare expenditures are 24% less than for others. It's a special case. Health center patients are those who are most vulnerable, most impoverished, most difficult to serve, and have nowhere else to go except the ER. But FQHCs are a special case. It's a special case in terms of what is this administration going to do, and what kind of America are we going to become. So the FQHC story, I can't help but say a word. It started back in 1965 with the OEO. And Dr. Jack Geiger found a way to snaggle a little of this money intended for social purposes into healthcare with a false start in Mississippi, then moving to Mound Bayou, Mississippi, Columbia Point, Massachusetts. As it happens, about 8 months after Mount Bayou was established, I drove through with a classmate, first year in medical school, and my classmate was to do his first clinical exposure while I was on my way to the Navajo Reservation in Arizona. We stopped and we saw this health center, and it was sparkling. It's just like we have now. And we got to see the town. We had dinner at an outside cafe because there was no inside restaurant. And all these kids came up, 2 white guys. And among other things, personal story, I had to ask, where are we going to stay? And one kid says, we can stay at the Flamingo Motel. And the other one says, oh, no, you can't stay there more than an hour. A real health center town. But then what happened was, in 1975, 10 years later, there was a statutory basis for making health center grants available on a more sustained basis. 1990, we became federally qualified. So we could be treated partly as if we were the federal government. Malpractice, as if we were Army doctors. Specialized reimbursement for Medicare and Medicaid through the PPS, Prospective Payment System. Eligibility to buy pharmaceuticals as if we were the federal government for the Army or the VA, so we could capture the profit margin belonging to Big Pharma. Those are what have sustained a safety net for now 23 million people, over 1,330 health centers with something like 9,000 sites across America, all exposed. So the exposures are, in the ACA, there was a trust fund of $11 million that enabled us to double the scope of community health centers. And as that expired, not now, but 2 years ago, there was a fiscal cliff. And we climbed the cliff thanks to the SGR, the doc fix, and the Child Health Plus, which had to be extended. But this October, that funding, 70% of all grant funding for community health centers expires unless there's a congressional fix. One challenge. Another is state flexibility. That we have many, Medicaid directors who are skeptical about this kind of primary care financing for people who may not be deserving and are looking to cut back on the prospective payment system that assures viability for those who are insured, who have Medicaid. You've heard about block grants, yet another reason for concern. How will block grants be distributed? Will it all go to hospitals? And then there's also 340B, which is a related issue attacked in part, most of all, by guess who? The pharmaceutical manufacturers who don't want their profits eroded by sharing it with safety net providers. So there's reason for hope, I think. One hope is that FQHCs, federal community health centers, have been one of the very few areas of consensus between Democrats and Republicans over the decades. And this could be one place for Democrats and Republicans to show that they can work together and climb the cliff, among other responsibilities. And wouldn't it be nice to think that that could be the basis for a larger discussion then extending to other aspects of healthcare policy? Another reason for hope, and this is really grandiose, is for the Republicans, it's impossible to imagine a more conservative, workable solution than Obamacare. There is no other. So the Republicans are facing the Winston Churchill problem of this is the worst health fix ever, except for any alternative. And there is none to be found. But we have our reasons for weirdness, of course. One is Tom Price, who has opposed about everything. He opposes bundled payments as too experimental and too dramatic and too risky. And yet his solution has very clever ways of making health care available to those who really need it. And that is, it allows people who are facing the required minimum distribution of their tax-deferred investments to be put into health savings accounts so they don't have to be taxed on those. This is a time when working people who voted for Donald Trump averaged $30,000 in net gross investments. So where to go? And then we have the Planned Parenthood issue, in which we have Paul Ryan, among others, claiming we've got a solution for that. We're going to take all the Planned Parenthood money and give it to FQHCs. cannibalism within the healthcare world.
Thank you, John. That was eloquently said, and I think certainly something that I agree with wholeheartedly. I think we all are going to wake up tomorrow and there will be a healthcare system. People will actually get medication. There are doctors. There is primary care. But I think that it's our sector, and it's a sector that we need to also make sure that we understand what the dangers are, what the potential erosions are, and how to protect it so that going forward, that is one of the things that we can, in fact, count on. So with all that having been said, what I'm going to do is I'm going to jumpstart some of the conversation. Then I hope that you all will be thinking about questions that you may have for the panel, concerns that you want to raise. I do want to point out that on your chair is a set of primary care principles that PCDC has developed. We hold these truths to be self-evident, that primary care, that coverage should be universal and affordable, and support early and consistent access to primary care. Primary care services should be comprehensive, and they need to be sufficiently reimbursed. And these will principles that we will hope that you all will sign on to, and that we will really promote and argue for in this context of what we're doing. We encourage you to give us feedback on them and to help us distribute them and to make sure that that's part of the conversation around repeal and replace. So let me start the conversation. So a hallmark of the GOP platform has been that Obamacare is horribly broken, hugely expensive, non-competitive, fundamentally flawed, the worst thing in the world, and must be repealed on the first day of the new administration, which they did technically do. So what are they talking about exactly? Can you share some light on what is it that was such a flashpoint about the Affordable Care Act that it became, in some ways, the centerpiece of the platform on the Republican side?
Wow, that's actually really a tough one, which I think we'll all have our own opinions about. But I think it goes back to 2009, the summer of 2009, with the rise of the Tea Party and the organizing around things like death panels. So I think it's important for us to remember that it started in communities, the same communities now, let's remember, that are depending on it. So, right, 2009, there were those horrible town hall meetings, death panels. Obamacare was horrific. That was the summer of 2009. Remember, during the State of the State in January, You Lie came out. So there was this anger that was built up about Obamacare, and it didn't dissipate in 2010 when Obamacare passed. It didn't dissipate with the Supreme Court decision in 2012 with the re-election of Obama. It did not dissipate. And I think that, and then there were the multiple repeal votes, right? It was every vote in the House to repeal it, to repeal. And it was building a narrative that bore little relationship to the reality, which is not to say that Obamacare, or the Affordable Care Act, doesn't, we wouldn't be sitting here under a Clinton administration talking about how to make it better. That's not the issue. When you mess around with 17% of the GDP, you don't get it right the first time. You have to be able to come back and fix it, something we could never, ever do, because we lost the narrative. And then we thought in 14, when the marketplaces were stood up, not so well in the beginning, but people could access subsidies. The Medicaid expansion took hold ultimately in 31 states, but we never changed the narrative. And how many votes did they take in the House to repeal it? So I think our job now is to change the narrative. And that's why they came in. It's the dog that caught the car, right? Now they're stuck with it and they don't know what to do, because there are too many things in there that people like. And there are too many things that matter in our economy. And so I think that's what happened. We lost the narrative, and we have to regain it under very difficult circumstances.
My patients don't want to be told what to do. I don't want to have to pay a tax to buy health insurance that I might not need or not do, and I don't want to do it. except for those patients who got the benefit. My most interesting patient along those lines came in one day to me short of breath. And so I said, it sounds like there may be something. Got an echocardiogram, had him come back and said, well, you know, you have congestive heart failure, and we're going to have to treat this. And this patient said, thank God. I said, what? He said, just last week I signed up and got health insurance for the first time, and now I can treat my condition. So the people getting a direct benefit know wherever they may live, but in rural areas like ours, being told you need to do something and have to pay money for it for the first time is a real shock. And there's been no adequate explanation of what the benefit is.
Right, we lost the narrative.
Yep.
Any other comments? I mean, I do think that there is an issue that we struggled with around affordability. So it wasn't nothing. It didn't cost nothing to get this health insurance. And there was, I think that was a tricky proposition. So I think particularly those, I mean, when we're talking about, 100% of the poverty level, what is that? It's $11,800.
Right.
Let's be clear. That's what 100% of the federal poverty level is. 138%, not a whole lot more of that. 400% of the poverty level, where you could actually get to the essential health benefit, is not very much either. So for if you're just above that, maybe you're making $40,000, $50,000 a year. The idea that you would have to pay, $500 a month for your family to get health insurance, and you're required to do this, I think seemed unimaginable. And I do think that there was a tranche of people in that was one of the things that didn't quite get figured out, is how do we think about that. But along the way, I do agree that the narrative has been, I want my health insurance, but not that Obamacare thing, or I don't want to pay for someone else to get good care. I want to, what about me? And I think that we did, there is that affordability problem, which we really didn't solve. But as you point out, we didn't have the time and the ability to do that.
To solve it.
But I think, going back to the issue of narrative, I also think that we tend to sort of demonize the other, and the idea that this is not a basic human right that we should all have access to just baffles me still. And as a doc, maybe it's a different vantage point, but the reality is, this should be a basic right that we all have to get access to care in a reasonable way. And the fact that we don't want to take responsibility for that in whatever way that means. If I want a car, I have to get insurance for my car, and I don't even think about it. I mean, this should sort of be akin to that. But I think by creating these sort of dichotomies of there's the other, this group of individuals that are sort of glomming on, us, I think that's the rhetoric that was created. And I think, without being incredibly provocative, I also think a lot of the issue around the Affordable Care was the fact that, it was Obama's, and, there was still this deep-seated, I just think, inherent racism in the way that we perceived him and what he was trying to do. And, people don't want to acknowledge that, or sort of call me a little bit, off on that. But I think that was part of why there was such vitriol around this issue, where this is not a debate. It shouldn't be a debate. I mean, this should be something that we should all feel comfortable thinking about. Everyone should have access to care, because the long-term impacts are such that we know that, sort of criminal justice and education and housing and all these things also do better when people have access to care. So I think that was part of the rhetoric around that as well.
So let's talk about the replace part of the equation, right? So interestingly enough, all the replacement plans the people who put them in knew that they were going to get vetoed, so they could put in anything they wanted, right? That was, and really it was about just, it was about the narrative, and it was about putting in an oppositional of an opposition to this thing that had been developed. So I guess the question is, what do we think is really, what do we think are really the core fundamentals of what will be put into any replace plan? You talked about the money going to the states. That seems to be pretty clear that in some form or another there will be shifting of dollars to the states. Do we think that will come with less regulation? Do we think CMS will say, listen, you guys, now it's all yours, do what you want, eligibility, it's up to you, what's in the benefit package, no more waivers because we don't really care about it, it's all going to you and you all have to manage your dollars? Or do we think that there will be a significant set of oversight that will continue to happen at the federal level that will require certain things or hinder certain things or disallow payments to be made for certain things. I mean, just some sense about what we think will be in the replaced
I think you
plans.
have to separate Medicaid, and then let's talk about the subsidies that are now available. So for folks above Medicaid, I think on Medicaid, the replace is about block grants or per capita caps. That's what replace is in Medicaid. And so will we be able to stop a capitated program, block grant or per caps? And if we can't, how much dollars will be available? What happens to the $72 billion that funded the 31 state expansion? That's one piece of it, and that's what replace in Medicaid looks like. For the subsidies, it's much harder to know. I mean, the repeal bills repeal the subsidies. The replace bills that are out there aren't bills, they're mostly concept papers. And when they talk about what replacing the subsidies, they're generally reduced or they're spread across more people. There are proposals to make them, instead of being tied to income, tied to age, which would have the obvious impact. And so we really don't know what replace will look like. We can analyze the Cassidy-Collins bill that came out, which sort of goes to your point that the states could choose. You could choose to keep the Affordable Care Act as it is now, or you could choose to have the subsidies put into HSAs, a lot of attention to HSAs, into HSAs attached to individuals. So we don't know, and at the bottom line is what happens to the revenue. Do we still have revenue raisers to raise the money for the subsidies, and how will those subsidies go out? And that's the core of it. Now, of course, then there's the guaranteed issue. It's very hard to get rid of guaranteed issue. And there's things like, well, guaranteed issue holds as long as you keep coverage, and you don't go without coverage. But what if you're of modest income, you go without coverage for 6 months because you can't afford it? Then can you be discriminated against in two ways? You could be denied coverage because you have a pre-existing condition, or your coverage can be community rated, and because you have some pre-existing condition, you will be charged much more. So we have the dollar piece, and then we have the consumer guarantees. And honestly, we don't know what's going to happen there. Right. And then, of course, we're going to sell insurance across state lines, and that will solve everything.
Right, apparently so. I mean, I think that was one of the core things in the Price, who will be we expect will be the new HHS secretary, right? That his plan for Indiana included if you fell off coverage, then guaranteed issue no longer applied, right? You could be discriminated against because of a pre-existing condition. And we can all imagine, so what was, in the New York State Medicaid program, what was the churn rate? Just of people who were, it was huge. It was huge. Yeah. Someone here must know. But, we're really talking about.
I think that's right. This is about 40%.
40%. Okay, so then really, if you miss the announcement in the mail, now you're no longer covered for whatever reason. Now you are subject to a whole series of things which will reduce your ability to either get coverage or to use the coverage that you might in fact get.
I don't think we can find an answer to this until we see President Trump's plan that will include coverage for all at less money.
Yeah.
Right.
That he's promised us.
Huge, beautiful. It's a great plan. Great.
Yeah.
Right. But I think that it's really important to keep our eye on what has already been stated as in either the two plans that I think people really talk about is the Price plan or the Ryan plan as being sort of the most likely. I'm going to ask one more question, and then feel free to get up, and there are two mics here if we want to take some questions from the audience. So I want to go back to this whole issue, of Planned Parenthood and women's reproductive health, which I think is really quite critical. Paul Ryan on January 12th said, by putting the dollars that we take out of Planned Parenthood into community health centers, which provide the same kind of services, they're vastly bigger, there's many more of them, and they provide these kind of services without all that controversy surrounding the abortion issue. Do we think that's real? Do we actually think that the community health centers, even if they were given another doubling of funding, which they got, and you're right, community health centers are in fact bipartisan. Under the George W. Bush administration, there was a doubling of community health centers, and I think we may well see that again. The question is, if all that money from Planned Parenthood goes into community health centers, will women have adequate access for contraceptive services and other reproductive health services that they need. So John, I'm going to put you on the spot and ask you that question, and then Cynthia, certainly feel free to weigh in.
No, I mean, I think there's a heritage belonging to Planned Parenthood that makes it an easy place to go. It's understood to be free. It's understood to be specialized in a good way, and I just know that FQHCs can't do the same job. Not going to do it.
Well, that's easy. I thought I was going to have to fight with them. I agree, and I'll expand on that a little bit. I mean, I think that's for a whole variety of reasons, right? In 2/3 of counties that have Planned Parenthood affiliates, those centers provide safety net care for more than half of the women who need publicly funded care. So, and that's now. So then if you look at an increased number of women, most likely without insurance, I mean, the task of absorbing all of those patients and all of that care is just, it's huge. And it's not, just from a capacity perspective, it's not doable. And then, as John mentioned, Planned Parenthoods are specialized family planning centers. FQHCs have to cover the whole gamut of primary care, and many of them refer to Planned Parenthoods for family planning care because that's what Planned Parenthood does, and they do it very, very well. And I think because that is their area of focus and their specialty, and they cater to those needs, they also provide that care better than most FQHCs and most health departments, in that Planned Parenthoods offer the full range of contraceptive services, whereas most FQHCs don't. They offer some or a few. Planned Parenthoods are set up so that they can provide pills on site. So you don't have to get a prescription, go to the pharmacy, fill that. You can just do the prescription and it's filled right there on site. They can also do same-day insertion of injectables and IUDs, so there's not multiple appointments that you're waiting for. If you push all of that towards FQHCs and then have to look at all the indicators that you'd want to measure for, is this working or is it, FQHCs would be, yes, they'd have more money thrown at them, but they still have the same infrastructure and the same provider networks right now. They still have the same level of expertise and the care that they have to provide. And I think the answer is just absolutely no way.
So again, I invite people to come up, but let me just, one more question is John, the fact is, and the Congressional Budget Office has said this, is that we expect to have a huge proportion of people who are currently insured become uninsured again. And one of the hallmarks of a federally qualified health center, and actually Planned Parenthood and women's reproductive health centers, is they accept everyone without regard to their ability to pay. That is a hallmark of the safety net.
And a requirement.
And a requirement, a federal requirement for both of those, by the way. In Planned Parenthoods and anyone who gets Title X funding, it's actually at $0. They have to be able to get those services at zero. I think there's a sliding fee scale for federally qualified health centers. But what will happen to the federally qualified health center system? You can't double the number of federally qualified health centers in a minute, right? It takes a number of years. You have to build new sites, and you have to find new primary care providers. You have to do a lot. What will happen with all these uninsured, now uninsured again people? Will you be able to take care of them all?
Yeah, one prospect are long waiting lines. We can't refuse to care, but if we can't afford to hire the practitioners, you can't squeeze people into care that doesn't exist. The most draconian experience I've had is polling my patients, who again are overwhelmingly Trump supporters and all the rest, and after the election having them say, well, we're going to have real change now. I says, yeah, I hope it's all okay. I said, well, what could go wrong? And I said, well, you could lose our health centers. And the jaws drop. Like, really? That could happen? Never thought of that. You depend on this stuff, or that was all in the newspapers, and so I just think there is a vast ignorance in terms of the implications of what's undertaken. and further concerned that once there is a collapse in whatever way, either longer lines or closures, that's because Obamacare failed. That's not us. That was all in the works. It was all unaffordable, and now they couldn't do it. And so we just have to be prepared to have a better message line and a better story and a better narrative than we've had up to now.